Haploidentical hematopoietic stem cell transplant has the benefit of guaranteed donor availability for practically every patient. Haplotransplant also avoids the delay in searching for a matched unrelated donor, with a potential consequence of disease relapse or progression during the waiting period. Current haplotransplant approaches profoundly deplete all T cells and remove or kill immune populations that are critical for a graft-versus-tumor effect, and most importantly, that's natural killer cells and gamma delta T cells. The immune reconstitution of these cell populations takes several months to a year and blunts the graft-versus-tumor effect at a crucial time when minimal residual disease could potentially be eradicated and the patient cured. In our trial, we are using a graft engineering method that selectively depletes alpha beta T cells and B cells from the graft, ensuring that large amounts of natural killer cells, gamma delta T cells, and other immune cells are transplanted together with non-manipulated hematopoietic stem cells while minimizing the risk of graft-versus-host disease. In addition, preference is given to a donor with favorable KIR-KIR ligand mismatch to boost alloreactivity of natural killer cells. The myeloablative conditioning regimen for patients with leukemia consists of rapid ATG, fludarabine, thiatepa, and TBI. Patients with solid tumors receive a reduced intensity conditioning regimen with ATG, fludarabine, thiatepa, and melphalan. To activate gamma delta T cells and NK cells post-transplant, all patients receive zoledronate starting at post-transplant day plus 28, administered every 4 weeks for a total of 5 doses. The primary study endpoints of this trial are engraftment and incidence and severity of graft-versus-host disease. Secondary and exploratory endpoints are immune reconstitution, activity of immune cell subsets, and disease-free survival. Some of the key eligibility criteria are availability of a suitable haploidentical stem cell donor, and the patient must meet standard organ function and performance requirements. For hematologic malignancies, they include very high risk or relapsed leukemia and current remission, relapsed lymphoma after failed autologous transplant or an autologous transplant is not deemed appropriate, and no HLA-identical sibling or suitable unrelated donor available, or the time needed to find an acceptable unrelated donor match would likely result in disease progression. Solid tumor patients are eligible in the relapsed or refractory setting who failed autologous transplant, or a transplant in that case is not deemed appropriate and the disease is considered stable. We also include patients with very high-risk features, that means less than 20% survival, then they are eligible in first complete remission. As with other allogeneic transplants, patients will be hospitalized for about 3 to 6 weeks until deemed ready for discharge, and patients need to remain in close proximity to our hospital facility for the first 100 days, for instance at our Ronald McDonald House, after transplant for close follow-up and scheduled assessments. As I mentioned before, starting at day plus 28, patients will receive zoledronate infusions in the outpatient setting every 4 weeks for a total of 5 doses. Additional scheduled hospital visits in Madison are required at the 1- and 2-year time points after transplant.